levator palpebrae superior, that raises the eyelid. So that opens the eye. When we did the blink reflex, 5 is the cornea, 7 is you close the eye, 3 is you open it because the oculomotor nerve innervates the levator palpebrae superioris. In fact, now this stuff is going to be on the written, okay? Well, if you look at the six muscles, the lateral rectus is innervated by the 6th nerve, the superior oblique is innervated by 4, all of the others are innervated by cranial nerve 3. So that would be, include levator palpebrae superioris.
And that just has to do with movement, correct?
Right. So when you're following something with your eye, you're moving your eyeball around, and they're coordinated. They're linked together reflexively in the brainstem. So if I'm testing cranial nerves 3, 4, and 6 like this, I say hold your head still and follow my finger. I'm going to test the different movements of your eye, and then I'm going to do accommodation and convergence. Okay? That's how that works. So the 6 muscles are, there's the levator palpebrae superioris. This is from the top. You have a superior rectus, a lateral rectus, a medial rectus, and an inferior rectus. You have 4 recti muscles. You have a superior oblique. It comes up, it's got a little thing called a trochlea here. It's a little sling that changes the direction and attaches to the globe here. So the recti muscles, they rotate the globe either up, down, medial, or lateral. The superior oblique comes in here and goes like that, and it rotates the eyeball. There's also an inferior oblique that does the same thing. An inferior oblique. You can see the inferior oblique right here. It rotates the eyeball. The superior oblique is innervated by the trochlea nerve. The lateral rectus is the abducens. All the rest of them are by the oculomotor. There's confusion about this, so if you start researching it or looking it up online or reading in the anatomy books, you're going to get confused. This is the actual motion of the action of the muscle if you were to only contract that muscle. But you never only contract that muscle. So the actual movements of the muscle in isolation, they're not relevant to clinical medicine. Ignore this for the rest of your natural life. This is the only thing you need to worry about up here. And it's basically this. The only 2 pure motions are lateral and medial. So if I do this, that lateral, can you stand up right now? If I do this lateral rectus is contracting, and that medial rectus is contracting. So I've got that LR6, medial rectus is oculomotor. And then I go the other way, and I do it opposite. So it's that abducens, that oculomotor. Now what I want to do is I want to test SO4. The best way to test SO4 is where you see right here, superior oblique. The actual movement of superior oblique is down and out. But the way you test it is to have the patient look down and get back up there. Is to have the patient look down and in. So I go this way, I go that way, I go up, that's inferior oblique, I go down, that's superior oblique. and then I do the accommodation and convergence. Okay?
Done.
You're done, okay. Now, the reason there's a difference between these two is if I'm going to look down and in, it's a combination of, so here's the medial side right here. I'm looking down and in. I've got the medial rectus pulling inward, the inferior rectus pulling it down. If I had two different muscles acting on the eyeball from different directions, this one wants to pull it that way, that one wants to pull it that way. If I tried to look down and in by using just these two, I'm going to wind up looking down and in like that. What I'm going to do is I'm going to put tension on it this way. So by putting tension this way, I'm able to rotate my eyeball smoothly down and in. And that's why there's a difference between these two. People who have a problem with the fourth cranial nerve have one of two complaints. Either they say that when they try to read, they have blurred vision or double vision because one eye is not looking down and in appropriately. So they have blurred vision. The other thing is, every time I try to walk downstairs, things get fuzzy. My vision gets fuzzy. What are you doing when you walk downstairs? You're looking down and in. Okay? Reading, walking downstairs, that are telltale signs there's a fourth nerve problem. Strabismus is just where your eyes are not lined up perfectly. That's all we're going to talk about. I mean, that's just in case your mom asked you this weekend. Here are the structures. There's the supraorbital, the artery vein. There's the supratrochlear. The eyelids, infection of the eyelid is called blepharitis. B-L-E-P-H-aritis. Blepharitis. You need to distinguish that from balanitis, which is an infection of the glands of the penis. Don't get those mixed up. Blepharitis versus balanitis. The peroneal, while we're at it, the peroneal is this part of your leg. The perineal is your junk. Don't get those words mixed up either. Okay? Got numbness in the perineal. No, they don't. They've got peroneal. So don't get that mixed up. The arterial supply of the orbit is all the ophthalmic artery. There's the central artery of the retina. Where is it? Right there. Entering the optic nerve. So the ophthalmic artery supplies the retina as well as the orbit, as well as communicate with the external carotid around the orbit, which you see here. Here are the veins that we talked about, superior and inferior ophthalmic veins communicating between the facial vein and the cavernous sinus. Now we focus on the ear for about 5 minutes. The ear is, this is the pinna, P-I-N-N-A. The pinna is the cartilaginous part of your ear. Its only purpose is for piercing. Actually, no. This is the tragus. That's the helix. That's the antihelix. And that is your lobe, your ear lobe. There are other parts to the pinna that I'm not even going to talk about. But helix, antihelix, tragus, and the lobe. Some people pierce their tragus goes through cartilage. You have your tragus pierced?
We both do.
You both do, both freaks.
Maybe we'll do the claimants for migraine. Is that why you got it? For migraine?
Yeah.
Does it work? Does it actually work?
No, I've actually heard that was the, one of the
Helix.
sinus.
Yeah.
That's a, acupuncture thing.
Okay, so there is cartilage inside of here, obviously, with an overlying skin. There's not much subcutaneous tissue here, so any bruising of this area, you've got to get the hematoma out. You've got to incise it and drain it, otherwise you'll wind up with what's called cauliflower ear. If you just Google the images of a wrestler, you'll see what a cauliflower ear looks like. Several of the wrestlers when they eat over in the cafeteria, even though they wear ear protection, they have chronic damage to the pinna, and it distorts it. So when you have somebody coming into the emergency room, you have to incise the blood out and put a pressure bandage on it to keep that blood from clotting and forming a permanent disfigurement of the pinna. This is really the only thing the rest of the slides in this thing, trash them. This is the only thing I want to talk about right here. External auditory meatus, external canal. There's your tympanic membrane. The damn eardrum is not positioned straight up and down. As you see, it's positioned at an angle. When you look in an ear, at the eardrum, there will be a reflection back at you. That's called the cone of light. Let me just show you in a subsequent slide, and it will, right there. So when you're looking at an eardrum, this is what you see. That's the cone of light right there. And it's a reflection is all it is. If the eardrum is distorted because of infection behind it or fluid behind it, then you lose that reflection. So in describing the ear exam, you would say the cone of light is present. So behind the eardrum, which is sealed, is the middle ear. The middle ear contains the three ossicles. I have ossicles over in the lab. I'll pull out so you can see the ossicles, the different ossicles. You have the malleus that attaches to the TM. You have the incus in the middle and the stapes that attaches to the inner ear. The inner ear has two components. One is the cochlear portion, the other is the vestibular portion. The cochlear portion is this conical shaped spiral ear, and that's how you hear sound. We'll go into the hearing sound and the auditory pathways in neuroanatomy. The ganglion that's associated with this is called the spiral ganglion. I don't know where it is up on the slide. The spiral ganglion contains bipolar neurons. The other part of the inner ear is right here, related to, that's the vestibular portion, that related to balance. And we'll go through that when we do neuroanatomy as well. That's really a complicated system. The middle ear communicates with the back of the nose through the eustachian tube or the auditory tube or the pharyngotympanic tube. That's why you can pop your ears by holding your nose. That is open. So when you have a sinus infection and you have, or a cold or something, you have all this nasal congestion and you have ear pressure and pain, what's going on there is the nasal mucosa swells and blocks that tube, so your middle ear tries to equilibrate itself by filling up with fluid, and that's what causes the pressure. So when you have that on your ear, the fix is not the ear. The fix is to use a nasal steroid to shrink the membranes here so you can open up that tube. And if you've ever had that tube open when you're awake, you suddenly feel this gush of mucousy, gooey fluid down the back of your throat. There you go. You know that one thing that's kind of cool about the vestibular area is the 3 semicircular canals. They're filled with fluid. And so if this is the inside of the fluid-filled semicircular canal, the movement of the fluid is what allows you to keep your eyes moving and tracking no matter where your head is in space. Because the movement of that fluid determines your angular and motion and velocity, acceleration. So that's why I can sit here and my vestibular nerve is connected to my extraocular eye movement muscles. And that way I can keep my eyeball, my head focused on this thing no matter where my head is in space because of the movement of that fluid inside those semicircular canals. So if I turn my head like that, my eyeballs, it takes just a split second for my eyeballs to catch up to it, right? Because you got to move the fluid. So if I turn my head quickly, the fluid takes just a second to start moving, right? But if I keep moving my head, eventually the fluid's going to be like that. Let me do it this way because this is bigger. The fluid's going to keep moving, right? So you're going to think your brain is telling you you're still moving. So let me get you to come down here. Okay, so I want you to sit there. I want you to turn as fast as you can. Keep going. No, I want you to keep going. Hold your head still. Come on down. Come down here. Come down here. Come down here. All right, keep going. Keep going. So what we're doing is we're getting her fluid moving in her semicircular canal. Keep going. Keep going. Now when she stops, don't stop yet. Keep going. When she stops, you're going to see her eyes do this. Okay, ready? I want you to stop and look at her. Taylor, right? Taylor, right? You see it?
I see her eyes.
Look at it. Keep going. Keep going.
What's the tickets when you're drunk to you can't control it? That muscle that's when you look to the side.
That's called nystagmus in the highway patrol. Okay. Right, stop and look at these guys. You see her eyes will twitch like that. That's because of the movement in that thing.
Is this why dancers spot when they turn?
What's that?
That's why dancers spot when they turn because
Yeah,
the fluid is.
you're trying to keep the fluid from moving.
They stop.
When we get to neuroanatomy, I'm going to do all sorts of things to you to reveal weirdness about the nervous system, and that's a simple little trick right there. Okay. I think we'll end there. Let's go cut up some brain. Any questions? Good.
We're coming back here, right, Dr. McNeil? Yeah.
For this afternoon.
Yes.
We're done with anatomy. Other than-
Can we leave our backpacks in here and you guys walk in the work?
I tried to email.
I wouldn't leave them in here because
So if you brought your computer.
Sorry.
if you want to leave them up